using the phone. Can you put flight mode? It will.
Oh, okay. Right. Okay.
I'm already.
Okay.
We'll wait for another 3 minutes. Okay.
If they are not able to share only, we have to.
Yeah, then only. Then.
Open with the mail.
Yeah, 3 will start around that.
Okay. Put up on reminder. One has joined.
25. You might have the video. They just off the video. Okay.
Okay. ಇಲ್ಲಿ ಮ್ಯೂಟ್ ಮಾಡು. ಕಂಟ್ರೋಲ್ಸ್ ಎಲ್ಲಿದೆ?
We can't see the slides, Murli.
So no problem. We'll want to
I haven't shared it yet.
Yeah, no
Okay,
problem.
fine,
You
fine,
can
fine.
wait. You
Yeah.
can wait. No problem.
Okay, okay. Now, whenever you're ready, I'll start screen share. No problem.
We're starting in another minute.
Ah, wonderful, sir.
Yeah.
Unmute ಹೇಳಿ.
So we can. Good afternoon and welcome to all for this monthly session of JIPMER Scientific Society. And today we have a special guest to give a lecture. And along with me in JIPMER studio, we have a Dr. Mamta, Secretary of JSS, and Dr. Balaji, Associate Professor of Psychiatry. And this invited lecture will be followed by scientific paper presentations. So I request Dr. Balaji to introduce the speaker.
It is my pleasure to welcome Professor Muralidharan from NIMHANS. Professor Muralidharan is a professor of psychiatry and currently he is the medical superintendent at the National Institute of Mental Health and Neurosciences, Bangalore. Sir has been a faculty in the Department of Psychiatry at NIMHANS for the last 13 years, since the year 2007. And his main academic interest is in the field of bipolar disorders and brain stimulation methods in psychiatry. Sir has also been to Canada for 1 year in the year 2012 and 13 as a visiting professor faculty, and has done a fellowship under Professor Lakshmi Yatam, who is he's a very popular researcher in the field of bipolar disorders today. Sir has also won several Young Investigator Awards, including one from the Indian Council of Medical Research and the Department of Science and Technology, Government of India. He's also received the prestigious Samuel Gershon Award twice. This is an award given by the International Society for Bipolar Disorders. He's won the award twice in the year 2017 and 2020. He has 30 key papers in the field of bipolar disorders and several more, and 6 book chapters to his credit. Not only his academic achievements, but also Sir has been a very resident-friendly faculty in the Department of Psychiatry, NIMHANS, and hence he is the best person to take us through this topic today on mental health of healthcare workers during the COVID-19 pandemic. So I would hand over the mic and dais to Professor Muralidharan, sir.
Thank you so much, Balaji, for that very warm introduction. I hope I'm audible.
Yes, you are audible.
Wonderful. So I'll start screen sharing now. So at the outset, let me thank JIPMER Scientific Society for giving me this honor of being your external speaker for today. It is indeed an honor when you get invited by a premier premier medical education training institute in the country, one of the institutes of national importance, and it's indeed an honor for me to be addressing the faculty members and probably students of JIPMER. So thank you. Today I will be talking about COVID-19 and the mental health of healthcare workers. I thought this is a good time as any other to talk about this important issue, which probably doesn't receive the kind of attention that it should be receiving. So the customary slides, let me start with thanking again, like I said, the JIPMER Scientific Society and my very good friend Mamta, who despite knowing me for more than 24 years, thought I'm capable enough to give this talk. So thanks Mamta for the confidence in me. And of course, NIMHANS for the opportunity to be able to sit here and talk to other important institutes in the country. So I'll start with a disclaimer. My talk has nothing to do with COVID-19. It is just incidental. I'm sure most of us have learned a lot about COVID-19 from the world's largest university through distance education. For those of you who have not guessed the university yet, it's WhatsApp University. So today I'm just going to talk about how COVID-19 is merely a catalyst for setting fire to what has been a simmering issue for a long time and that requires urgent attention. So this is the outline of my presentation. So I'll be talking about initially trying to set the context for my talk, a few slides on the mental health scene in India, a little bit about the health and mental health of healthcare workers, particularly in the context of COVID-19, what can be done, what has been done, and what has been our experience at NIMHANS in helping our healthcare workers in terms of their health and mental health. So let me start with the definition of healthcare workers. A healthcare worker is defined as one who delivers healthcare services to the sick and ailing, either directly as doctors and nurses or indirectly as aides, helpers, technicians, and even waste handlers. Now, a lot of us may not be familiar, even I was not aware of this till recently, that the decade 2006 to 2015 was declared as the decade of human resources for health by the WHO, in keeping with the importance that is attached to healthcare workers for healthcare service delivery. Now, in my talk, I'm going to focus more on doctors, and my apologies to other cadres of healthcare workers that I will not be talking about them in today's talk, simply for want of time. So this is something that I wanted all of us to pay attention to. This is the elephant in the room that nobody wants to talk about or acknowledge. That is the health of doctors, especially the mental health of doctors. This is something that has been ignored for too long, and this is something that we all need to wake up to and start paying attention. Now, why did I decide to talk about this particular issue? Mainly because of two things that happened in the recent past. One was as recent as 2-3 days back, the World Mental Health Day, where we talk about mental health for all, greater investment and greater access. So our priority should also be to ensure that there is greater access to mental health care for doctors. And secondly, what was observed on the 17th of September this year, the World Patient Safety Day. Now, in keeping with the COVID-19 pandemic that is going on, the theme for this year's World Patient Safety Day has actually been health worker safety, a priority for patient safety. The slogan for World Patient Safety Day has been safe health workers, safe patients. And the call for action has been speak up for health worker safety. So I thought this is as good a time as any, given that WHO has given this call for action. So let me start by speaking up for health worker safety. Now, to continue with setting the context, this is something that all of us are familiar with. A crowded OPD with absolutely no privacy for the patient or the doctor, which gives rise to this issue of stress among healthcare professionals. In this study, which incidentally was not done by doctors or medical professionals, but done by the press and published in the Hindu on 2nd July 2017, I don't know the denominator, but then as per their survey, almost 83% of the doctors reported feeling stressed out in their work. 46% of them reported that the stress was due to a fear of violence. 24% of them reported that they feared that they would be prosecuted by their patients. And almost 14% of them feared criminal prosecution. So you can understand the kind of stress with which the doctors have been working. This is prior to COVID, let me remind you, in the context of healthcare settings. Now, if you look at another more recent study, more recent as in 2015-16, that was published in the Indian Journal of Critical Care, which looked at the stress levels of doctors who are working in critical care. Now, the nation level survey that was carried out, I think they were able to survey about 2,000 plus doctors. And they came up with a list of 24 issues that almost all the doctors rated as a stressor. The most important ones being too much responsibility at times, managing VIP patients, being overstretched at times, lack of professional satisfaction, talking to distressed relatives. So these are some of the areas which the critical care doctors perceived as stress. And I'm sure there are a lot of other things in this list of 28 items that all of us can identify with. More important being, dealing with individual managers, appropriate salary or remuneration, informing relative about patient's death. So these are some of the situations that we're not actually trained for, but we tend to face in a day-to-day practice. And in the context of COVID, it is necessitated that almost all of us function as critical care doctors, irrespective of our specialization. And I'm sure most of you would also be doing COVID duty in the COVID care areas, working in COVID ICU. So this is a situation where almost all of us are forced to function as critical care doctors. So this entire list of stressful events that the doctors talk about practically applies to all of us in this current scenario. So moving on to the mental health in India. Now, this is the National Mental Health Survey that was published. NIMHANS was an important participant in this study, where we reported that psychiatric morbidity is there in about 10% of the population. So if you take the population of India and 10% of them suffer psychiatric morbidity, then the mathematics are scary. Severe mental disorders are seen in almost 0.8% of the population. That's almost a crore. A crore individuals have severe mental disorders. And I'm talking about very severe illnesses like schizophrenia and bipolar disorder. And this is the prevalence of depression in India. Now, the dark blue areas that you see, Uttar Pradesh and Punjab, these are the ones with the least incidence of depression, prevalence of depression rather. And you can find that all these states have almost 3,000 people with depression per 100,000 population. So you're talking about an extremely prevalent problem, which probably has been aggravated in the context of COVID-19. And this is the more serious issue, the treatment gap. Almost 70% of the patients with severe mental disorders do not have access to mental health treatment. The treatment gap is more for certain disorders like substance use and depression. And this is what we have in terms of the mental health care resources in India. So we have only about 0.03 psychiatrists per 10,000 population. That is much lesser than what we had in 2001. Thanks to Australia and UK, most of our psychiatrists are providing care there, while the treatment gap in India continues to become grossly wider. So newer problems because of COVID-19, the mental health treatment gap has actually widened. The COVID-19 itself has given rise to newer mental health problems, and this has actually ended up in increasing the denominator of patients and people who require mental health care. Now, the newer people who require mental health care include COVID diagnosed patients, patients who are in quarantine awaiting testing, frontline workers in the COVID wards and in the community. So a lot of doctors who are working in the COVID wards, the nursing staff, all of them are facing a lot of stress and mental health issues. Family members of these individuals who, again, are concerned that they are near and dear are exposed to COVID in these high intensity areas. Healthcare workers in non-COVID hospitals, especially where the workload has probably increased because certain important hospitals have been designated as COVID hospitals and were not accepting non-COVID patients. And it's still the case in many of the major hospitals across the city. And of course, mental health professionals who now have a bigger denominator to address. So moving on to the topic that I wanted to discuss with all of you, health and mental health of doctors. Now this picture that you see here is not something from India, but from the NHS. And if you look at some of this information that has been shared, it's quite alarming. You find that the suicide rates in doctors is almost 2 to 5 times that of the general population. 1 in 3 doctors use alcohol, drugs, or self-medication as a way to cope with their mental health condition. 40% of the doctors who experience mental health issues actually disclose it, whereas the rest of them do not disclose it for fear of stigma or loss of reputation. The most common symptoms that the doctors experience include anxiety, depression, and low self-esteem. 57% of them will only disclose this information to their family members, and only 28% of them will deal with this alone. So the rest of them are the only ones who actually seek help. So the number is actually very small. Yeah, so why do doctors suffer more mental health issues? So we've already discussed some of them, stress being one of them, burnout is another issue. Constantly being exposed to stressful situations results in burnout. A lot of people, identify stress as a badge of honor. I don't know how many of you are familiar with it, but we tend to hear our colleagues boast that I work continuously for 60 hours. I work continuously for 72 hours and, without a break. Now that's something, which can be an issue. It's not a badge of honor. You're actually overworking yourself. Denial is one such issue where we fail to accept that, yes, we could be having stress and mental health issues. Stigma, particularly doctors who have suicidal ideation, find it very, very difficult to disclose this information for fear that, they may be stigmatized. There's a lot of guilt that, maybe I'm not strong enough for this job. Fearing loss of job and reputation is one of the major deterrents which prevent doctors from seeking help for the mental health issues. So all in all, this contributes to a situation where loss of empathy is something that is experienced in doctors. The job becomes more mechanical and their ability to empathize with their patients tends to come down, which is unfortunate considering that the medical profession is the one that has the most empathy towards its users or customers, as the consumer court would call it. Now, so moving on to mental health, COVID-19, what are the issues that cause stress among doctors in the context of COVID-19? So the most important thing is that we are ordinary individuals who've been exposed to an extraordinary situation, which requires us to respond with a lot of equanimity in the face of stress. The number of individuals who require treatment has become disproportionate to the available resources within the country. The risk of exposure to self. Now, if you were to take the data that was available from the swine flu epidemic, we find that the healthcare workers are twice more likely to get infected than the non-healthcare workers. Lack of adequate protective equipment, certified equipment was one such concern which health workers, particularly doctors, have had over time. Looks like the shortage is not there right now, but then this was a major concern once upon a time, not once upon a time, a couple of months back. And of course, the risk of infecting our families, the major fear during pandemics. In fact, if you go by the data that was available from the swine flu epidemic, we find that 20% more family members of doctors were infected during the epidemic than other individuals, than the general population. Now, what are the common presentations of mental health issues in doctors during this COVID-19 pandemic? One such issue is absenteeism. A lot of people may want to stay away from work, reduced job performance and productivity, rapid changes in the mood state, anger outbursts, crying spells. So emotional dysregulation is something that can be seen as a result of the stress. Some of them may report to workplace intoxicated because they may have used these dysfunctional strategies of coping with stress by resorting to alcohol or other substances, impaired physical capability and daily functioning. And of course, another thing that is very peculiar to us as medical professionals is presenteeism. A lot of doctors feel that right now their presence is required in the areas where treatment is going on more than ever before. So they tend to come more regularly than is necessary. So presenteeism is another source of stress among doctors. In addition to this, a lot of doctors tend to suffer some kind of moral injuries as a result of some ethical dilemmas. A lot of it has to do with, okay, which patient should get the ventilator? If I have 5 patients, which patient do I decide requires my attention? Which life is worth saving more? So this kind of triaging that happens in the ICU or a critical care center can cause a lot of ethical dilemmas and probably some amount of moral injury that requires attention or help later. Distress and anxiety related to COVID-19 itself, substance use disorders, like I mentioned, sleep disturbances, and more importantly, a lot of doctors who may have had pre-existing mental health issues or may have received treatment for it are likely to face exacerbations of their pre-existing mental health issues. So these are some of the reasons, some of the ways in which stress and mental health issues can present to us as a result of the ongoing COVID-19 pandemic. So what can be done? So what do we do to address this issue? Now, I'm going to first start off with this COVID-19 related issue. So there are many things that can be done at an individual level, at a peer level, and at an institutional level. So the individual level, some of the important things that we need to look at is self-care, ensuring that we make sure that we have adequate work-life balance, make sure that we get adequate rest, make sure that we spend adequate time with our family members, take care of our health by, attending to any health issues that we may have, ensuring that we get help for our health issues, not necessarily mental health, any health issues at the earliest. To work on problem solving techniques, which some of us may be more competent to do than the others. So problem solving is something that all of us need to learn. Relaxation techniques, of course, a lot of relaxation techniques are available. Yoga is something that is being promoted to a great extent these days as an important relaxation technique. It's something that all of us should learn, should be able to practice. And those of us who have pre-existing mental health issues should ensure that we get adequate treatment, that the medications that have been prescribed are taken, and that we ensure that the pre-existing issues do not worsen during this crucial period. In terms of peer level, enhancing social support is something that needs to be done. We need to connect with each other more often than before, probably even virtually if required, to establish buddy systems at work. This is something that has been tried in many institutions where you have a group of people at varying levels of seniority who work together as a team to ensure that the health of each other is looked after. So this buddy system is something that can be done at the peer level. And at an institutional level, what can be done? We need to establish mental health support systems. This applies for all institutions and not merely institutions where a psychiatry department is available. All institutions should have a mental health support system. We need to enhance awareness among our healthcare workers about the mental health issues that can happen, particularly during stressful periods like this ongoing pandemic. We need to ensure that the family members of the healthcare workers, the doctors in particular, require adequate support, especially in the event that the doctor contracts COVID or suffers from mental health issues as a result of working in the COVID pandemic. We also need to remember that our doctors in quarantine and those who tested positive for COVID-19 and may be in isolation may have additional needs, may have additional mental health needs, which the institution should take care of and should provide support to. And more important than ever, the institution should ensure that the policymakers take note of the issues that the doctors face in terms of their health and mental health, and adequate policies are put in place to address some of these issues. Now, let me just share a few slides of what we've done at NIMHANS in order to take care of the health and mental health of our doctors and healthcare workers. So the first thing that we did was we started off with educating our staff. But okay, before I go into this, let me just, for the benefit of everyone else, share that NIMHANS is not a designated COVID hospital, unlike JIPMER or AIIMS, where you have designated COVID wards. NIMHANS is not. We are continuing to provide neuropsychiatry treatment. We've also taken care of the patients with neuropsychiatry problems who have COVID-19, in addition to taking care of the staff who've turned COVID positive in the last 3 or 4 months. So since March 2020, we've started this process of educating our staff. This is an ongoing process. Every week, some classes are conducted in small groups for different cadres. Of course, we use online platforms more now. The focus is on less informed groups like the outsourced employees, the cleaning staff, the security guards who need to understand how the disease is transmitted, what are the symptoms that the disease can present with, and what are the treatment options that are available. We also talk a lot about treatment and recovery and focus on the people who have shown improvement with treatment. Staff well-being is something that has been very, very important for us, particularly since the information that is provided by the ministry, by WHO has been very dynamic in the last 3 or 4 months. So it was important for us to ensure that information is shared. And this is very crucial to avoid misinformation. Otherwise, people are going to get their information from WhatsApp, which is going to make our life more difficult. So assurance that staff will be taken care of by the various hospital policies that we have formulated in the last few months. In addition, since the onset of the pandemic, we have been releasing what is called as an enhanced bulletin, which contains crucial information about the various measures that have been taken. You know, like the tagline says, breaking the chain, flattening the curve. So we've been sharing this information with all our employees. It was done on a weekly basis from the 1st of March till about end of July, and now we're doing it on a monthly basis. In addition to that, the general well-being is something that we have focused on. So the Center for Integrative Medicine at NIMHANS has been organizing tele-yoga sessions via Zoom twice a day for almost all the employees and their family members. They also run special packages for staff and family who have comorbid medical problems. And these sessions are streamed twice a day so that people can participate either in the morning or the afternoon session. Yeah. In addition, NIMHANS had launched the COVID-19 helpline. I think this was done in the first week of March, and this was to help people who may have mental health issues in order to contact NIMHANS to see if some kind of help can be obtained for their mental health problems. A lot of time, the helpline helps people who are distressed. So initially during the lockdown, it was more about not getting provisions, not being able to access healthcare, not getting medications. Whereas now the focus is more on mental health of staff and students who are working in COVID care facilities. So most of these people call us for their mental health needs, and appropriate help is provided. A buddy system has been established for faculty and residents on campus. You know, where 3 or 4 houses in the quarters area, they get together, they formed a system, they help out a family, one of them turns COVID positive. We have a single point of contact for students in the different hostel, a faculty member who will help them with their health needs and the mental health needs. And we've also worked on mechanisms by which we have been able to enhance peer support among the students. In terms of functioning of the hospital, we've created contingency plans across departments to make sure that not everybody is exposed to high-risk areas at the same time. The zoning of the hospitals into green, orange, and red zones were done almost 3 months ago. So the red zone is where we have our COVID positives. The orange zone is where we don't know the status of the patients. So green is where all the COVID negatives, staff and patient were. So the risk categorization of staff working in these areas and testing them periodically to ensure that, you know, infection in green zones do not happen is something that has also been very helpful in allaying the anxiety that a lot of staff had in terms of working in the COVID areas. We've also initiated the antibody testing, and, you know, almost all the staff have been tested, and many of them have now come forward to donate the plasma, which may be useful for some patients who may require it. Of course, the information on this is contradictory. We have a quarantine center of about 60 beds where staff who are awaiting testing, let's say people who've been exposed and need to be tested after 5 days, but do not have a facility to do so at home, we have some facility available where they can stay. Till date, about 145 of our staff have utilized this facility. Food is organized here. They also have access to free Wi-Fi, and the live streaming of yoga sessions happens even here. We also have a telephonic support program that is provided by our Department of Social Work and Psychology. They talk to them, reassure them. And we have a testing facility there, which would help the staff to get tested without having to go and stand in the long queue and other testing kiosks. We also have a COVID care center, which we started once the government said that home isolation is possible for people who are COVID positive. We have about 110 beds that were earmarked for them. At any given time, only about 20% of these beds are occupied, but we still have it available for staff and their family members who test COVID positive and do not have the facilities to isolate at home. Till date, about 162 staff and students have used this facility, and currently about 22 of them are there staying here and making use of the. And like with the quarantine centers, even here we have health promotion activities, telephone counseling, which happens at least twice a day. And of course, access to information and to all these programs is through free Wi-Fi that the institute has provided. And all these staff who who test positive for COVID are provided a COVID treatment package, which they continue to get while they are here and also continue it when they are at home. This has been given to all the staff of NIMHANS. And one of the key issues were availability of PPE kits. So we've been ensuring that adequate PPE kits are provided to all the staff and they feel more comfortable at work. And I must say that this has allayed the anxiety of healthcare workers to a great extent, though the cost has been quite high, but still. Happy and safe healthcare workers means a better workforce, and so their anxieties have been allayed to a great extent. In addition, NIMHANS has been actively involved with the policymakers across, at both at the national and international level. A lot of manuals have been developed in association with NIMHANS, which works especially towards the, enhancing the mental health of staff who are working in some of these high action areas, those who are working with vulnerable populations. So across the world, we've worked with policymakers to ensure that the health and mental health of the healthcare workers are taken care of or at least addressed in this important time. The other important thing that NIMHANS has been working on in the last 4 years, but which has been very important for us in terms of taking care of health of our healthcare workers, is the NABH accreditation process that we have been working on in the last 4 years. Our final assessment is due in the next week. But one of the important things in NABH accreditation is that the annual health checkup of all the healthcare workers, and that is mandatory. Everybody has to undergo their routine blood investigations, a chest X-ray if required, and they have to undergo an ECG and a complete cardiac evaluation, which is made available at NIMHANS itself. So this is something that has been going on for the last 3 years, the annual health checkup of all the healthcare workers, and to a great extent that was possible because of the NABH accreditation that we had initiated. Vaccination, particularly for hepatitis and all that, has been made available, and it is mandatory as per NABH to ensure that all the staff have been tested, and at least the serological tests are done to ensure that they're adequately protected. So this is one step that was a major step for us towards healthcare worker safety. So to summarize the points that I shared today, the health and mental health of doctors and healthcare workers, like we've discussed before, has been much neglected. The negative impact of the health of healthcare workers on the health of patients is something that is being recognized by bodies like the WHO, and hence the focus has now started to shift a little bit towards the health of healthcare workers. A little late, but still it's a positive change. It's important that all organizations must invest in the health of their own healthcare workers, particularly the mental health of their workforce. More importantly, we must ensure that we take care of our health and mental health adequately. Only then we would be able to serve our patients to the best of our abilities. And most importantly, there is no health without mental health. So let's make sure that we take care of our mental health and ensure that we stay healthy at all times. While I've covered some of the issues that pertain to mental health in the times of COVID-19, some of the issues that I've not actually touched about in this talk, but which would require a larger forum for discussion, would be this: that we shouldn't just work on tokenism and lip service, but we should actually move towards policy and decision-making in terms of the health and safety of healthcare workers. We should be the catalyst for change that you want to see. Each organization, each individual, each department should work towards bringing about the change that we want to see in terms of how the health worker safety is addressed. Change has to start within. It has to be more local. It has to start with individual departments. Only then we would be able to actually do what Lord Hutchison had asked us to do in terms of taking care of our patients. And like I said, we need to take care of ourselves. Only if we take care of ourselves, we should be able to take care of the other issues. I have not touched upon many other issues which are equally important and pressing, like, for example, violence against doctors and some of the other issues that are always there, and in terms of the infrastructure that is available for doctors to work with. But again, those I thought was a little beyond the scope of my talk, which was about health and mental health of healthcare workers. So I haven't touched upon those issues, but those are equally important. So with these few words, I'd once again like to thank JIPMER Scientific Society for giving me this opportunity to share a few thoughts with you. And thanks once again, and thank you so much for your attention.
Yeah, thank you for the nice and elaborative talk. And I'm sure we'll have some questions and clarification. The audio is okay? Are you able to hear?
Yeah, I can hear you, sir.
Yeah.
It's quite clear. Thank you.
Yeah. From my side, I have one question. So, in the academic career of the junior doctors and research scholars, the COVID has taken a major impact. So, surely this will be affecting their teaching, training, and confidence as practitioners and researchers in future. So, what are the exact psychological or psychiatric problems we expect when we unlock the system, health system once again?
Yeah, I think the primary thing that is likely to affect our, new young junior residents would be self-esteem. They're probably going to compare themselves with other people who have passed out before them or their immediate seniors like senior residents, and find that they're probably not as adequately trained, or they may feel inadequate in terms of their training, and that could have a significant impact on their self-esteem, which in turn could contribute to other problems like anxiety or depression. If not at a syndromal level, at least the symptoms are likely to be there, and this is something that we need to focus on. I'm not sure what has happened in JIPMER. So at NIMHANS, we've tried to ensure that the batch of students who joined in January, just before the lockdowns were announced and before the hospitals had to be shut down, we've ensured that they are a part of this buddy system that we've created with the student, with the senior residents and with other senior students, so that their training continues uninterrupted. We've also started using the online platforms for academic training extensively. We've tried to ensure that the classes which were going on regularly prior to the onset of the pandemic continue even after the lockdown was announced and the patients stopped coming, to ensure that some amount of training does happen. Of course, there is nothing like sitting with a patient in a consultation room and learning from the patient. Nothing can substitute that. But for want of better facilities, we've had to make do with what we've had. Thankfully, from June 1st, we were able to restart our outpatient services, and our inpatient services have continued throughout this period. So bedside training of residents is also something that we have ensured that it continues despite COVID playing spoilsport to training of our junior residents. But yes, sir, to answer your question, self-esteem is going to be a major issue, and it's the consequences of low self-esteem like anxiety and depression is something that we are likely to see to a great extent.
I am Dr. Durga Prasad. Hello, can you hear me, sir?
Yes, sir.
Yes.
Clear.
Sir, how to identify, because some mishaps happen, how to identify who are in stress, because everybody is not going to tell. I am from cardiothoracic, so sir.
Yes, sir. So I think that is probably the most important question that one could ask. And in fact, that is a question that we should ask ourselves, and we should ask people who are working with us. So, like I said, a lot of doctors don't want to come forward and accept that they could be facing stress or that they are stressed, simply because, we have this image that we need to maintain. A cardiothoracic surgeon probably has to be this very tough person who can handle any kind of emergency, whereas a psychiatrist doesn't have such images to worry about. So the question that we need to ask is, am I feeling stressed? Is this how I normally feel? Do I need to talk to somebody? And if we find that, people who are working with us, whom we've known to be good workers, whom we've known to be, very efficient people, if we find that they're not working as well as they were, or they don't look as cheerful as they were, it's always useful to reach out and ask them, is something bothering you? Can I help you in some way? I'm sure that is going to be the single most important catalyst in helping them come out with any issues that they may be facing, and probably will bring about a lot of change, sir. I'll just give you an example of something that we did here. So we have been conducting this well-being program for police personnel. So we're doing it for the Indo-Tibetan Border Force and for the Tamil Nadu State Police. And one of the issues that we were facing is that the policemen and women wouldn't go and tell their immediate senior that they were having stress or they were having mental health issues, simply because they thought that a black mark on their career would be disastrous for them. But after we conducted these orientation programs about what stress is and how relieving stress can actually help the police force perform better than what they're actually doing, we find that a lot of these senior officers are actually reaching out to their juniors and asking them, are you all right? And glad to say that almost 40 to 45 suicides have been prevented because somebody asked that question, are you feeling all right? Is something bothering you? So I think the question that you asked, a very important question, sir. And if we can ask ourselves, am I all right? Do I need to talk to somebody? Or if we can ask our junior colleagues, are you all right? Is something bothering you? I think that will help us identify, because stress varies from person to person. The stress for a cardiothoracic or a person or a cardiologist is very different from an anesthetist. It's very different from a dermatologist. But then stress is stress. And what one experiences varies from what another person experiences. So merely reaching out and asking would be a very important step in helping us identify whether somebody is stressed or not.
Thank you.
Good afternoon. I'm Dr. G.K. Pal here.
Good
I'm the
afternoon,
senior professor of physiology and in charge of yoga center.
Oh, wonderful, sir. Good afternoon.
Good afternoon. I just wanted to know how was the yoga therapy was given to your healthcare worker, number one, and whether
Yes,
this was a general yoga therapy or a specific yoga protocol devised exclusively for COVID-19.
Yes, sir. So we have 2 or 3 different things that are going on. So one is the yoga that we offer for patients. So the yoga that is offered for patients are modules that have been validated for particular disorders. So we have a yoga module for depression, for schizophrenia. Likewise, we have a yoga module for diabetes and some other medical conditions that are commonly comorbid with psychiatric illnesses. Now, as far as the staff and staff who tested positive for COVID are concerned, the yoga module for them essentially consists of breathing exercises, essentially a lot of pranayama. So if I can remember a few names, I think they do that Bastrika and Anuloma, Viloma, and some of those important breathing exercises. So it's a half-an-hour module which focuses more on some amount of Om chanting and Nadi Shuddhi Pranayama. So these are 3 or 4 important breathing exercises that have been taught for people who have tested COVID positive. Not many asanas are being taught to them. It's more pranayamas.
Thank you, sir. Thank you.
Thank you. Thank you so much.
Are there any other questions from any of the faculty or residents? We'll wait for 30 seconds more.
So that's going to be stressful for me, sir. It's good that I got this opportunity to see some friends through Zoom, thanks to Jitma Scientific Society. I thought I saw Dr. Ramesh log in. Hi, Ramesh. How are you? And of course, Mamta and Balaji were there. So thank you. That's an additional benefit of having logged in through Zoom.
Yeah, if there are no further questions, on behalf of Jipmar Scientific Society, we immensely thank Dr. Muralidharan for his wonderful talk and laboratory talk. And we were aware about your extensive work in this area. And you and your institute is, as an administrator, also helping the government of India to make guidelines and supporting documents. And on behalf of Jipmar and Jipmar Scientific Society, once again, we thank you very much for delivering this lecture, sir. Thank you.
Thank you. Thank you so much, sir. The honor is entirely mine. Thank you so much. So with your permission, I log off now, sir.
Sure. Okay. Thanks. We'll continue with the paper presentations. To deliver the scientific paper presentations, I request all the presenters to be ready with the presentation, and you can upload your presentation from your end. And one more request is please do not present from the mobile phones. You need a computer to present. So I request Dr. Mamta to call the presenters in their serial order.
Yeah. The first presenter in the original studies section will be presentation will be from Division of GI and Surgery, Department of Surgery. It's about 147 pancreatic duodenectomies, a single center's perspective into the epidemiology and surgical outcome of periampullary and pancreatic cancers in South India. The presentation will be by Dr. Saurabdeep Datta. So I call upon the presenter to share the slides and commence the presentation.
Good afternoon, respected faculties. Am I audible?
Yes, you're audible. Please go ahead.
Good afternoon. Today, the topic of my today's talk is 147 pancreaticoduodenectomies, our center's perspective into the epidemiology and surgical outcomes of periampullary and pancreatic cancers. Pancreaticoduodenectomy involves resection of the pancreatic head, duodenum, gallbladder, and the bile duct, and performing pancreaticoenteric, bilioenteric, and enteroenteric anastomosis. This requires a considerable degree of surgical training and expertise. Several factors like center effect, surgeon volume, and standardization of care affect the outcomes of the procedure. Pancreaticoduodenectomies are being performed at our institute since the 1990s, but there has been no published data available till now. The aims and objectives of my study are to find out the morbidity and mortality rates following pancreaticoduodenectomies in our department and how it has evolved over the last decade, and also to evaluate the epidemiological trends to see if any change is there in the incidence rates of various periampullary cancers in the Indian population as opposed to the rates from the Western studies. This was a single center observational analytical study done in the Department of Surgery, and the study period being from January 2010 to December 2019. The inclusion criteria was all patients who underwent PDs after a suspected or confirmed diagnosis of periampullary or pancreatic carcinoma in the Department of Surgery from January 2010 till December 2019. But the patients who underwent PDs in the other departments like Department of Surgical Gastroenterology or Surgical Oncology were not included in this study. For the sampling, a convenient sampling method was used. The sample size was 139. It was derived by using the single proportion formula, taking an estimated perioperative mortality rate of 10%, a margin of error of 5%, and confidence level of 95%. I started my study in 2018. The period before that, that is from 2010 till 2017, this retrospective data was collected from the OT registers, medical records department, hospital information system, JIPMER cancer registry, and the medical oncology records library. The patients were further followed up via phone and postcards. For the prospective patients, data was collected using patient proformas and were further followed up over phone after their discharge. The statistics was done using software SPSS 26 version. Continuous variables were expressed as means with standard deviation and are evaluated with independent students t-test. The continuous variables which were not following normal distribution were expressed as median with range and evaluated with Mann-Whitney U-test. The categorical variables were expressed as proportions and evaluated with chi-square or Fisher's exact test. Univariate and multivariate logistic regression test was used to see the association between the factors, perioperative factors to the perioperative mortality. A Kaplan-Meier plot was used for the overall survival analysis. Now coming to the results of my study. In the demographic data, we see the maximum number of patients between the 40 to 69 years age group with a peak between 50 to 59 years. It was normally distributed curve and the gender distribution was almost equal across all the age groups. In this slide, we see the number of surgeries being done every year. And we have seen, we see that from 2010 to 2019, there has been an exponential rise in the number of surgeries per year. Due to this, we have divided the entire 10-year period into two halves. The first 5-year period, 2010 to 2014, and the next 2014 till 2019. Till 2014, we see the number of surgeries per year were less than 10, and there has been a sudden increase in the number of surgeries from 2015. In this slide, we see the preoperative parameters. The diabetes mellitus was most common comorbidity in the study population, and among the clinical presentation, around 84% patients had jaundice, and around 5% patients had gastric outlet obstruction. Preoperative drainage was done in 24% patients, and there was no statistical difference in these preoperative parameters in between the two study periods. Coming to the operative parameters, classical pancreaticoduodenectomy was the procedure of choice, that is in 97.3%, and only 4 cases of pylorus preserving procedures were done in the last 10 years. Pancreaticojejunostomy was the dominant choice of anastomosis, with only 19% cases underwent pancreaticogastrostomy. It was the choice of anastomosis of one single unit. We also see a decrease in the blood loss over the 2 periods. There was a significant reduction in blood loss from 850 ml to 600 ml in average in the second period. This is a chart showing the different types of pancreaticojejunostomy and pancreaticogastrostomy which were done in various units over the time. Now coming to the postoperative outcomes or parameters, the 3 most important complications which happens following a pancreaticoduodenectomy are delayed gastric emptying, postoperative pancreatic fistula, and postoperative pancreatic hemorrhage. What we see is there has been a significant reduction in the incidence of delayed gastric, clinically relevant delayed gastric emptying and post-pancreatectomy hemorrhage between period A and period B. The incidence of post-operative pancreatic fistula rates were slightly increased in the period B, but it was not significant. Coming to the other post-operative parameters, we would like to see here that the perioperative mortality had significantly reduced in the second period, in the period B. From 27% in period A, it has decreased to 10%. There were no other differences in the other post-operative parameters. This is going to be a little busy slide. This slide shows the association of different perioperative parameters with post-operative pancreatic fistula rates. We see there has been significant association between ASS score, preoperative albumin, blood loss, pulmonary complications, postoperative sepsis, and perioperative mortality with pancreatic fistula rates. Other parameters like perioperative drainage, types of pancreaticoenteric anastomosis, duration of surgery did not have any association. This slide shows the mortality rates. Over the years, we see how the mortality rates, the proportion of patients having a perioperative mortality has decreased over time as the number of surgeries increased. This slide shows the logistic regression model according to association of various factors with the perioperative mortality. What we see is the postoperative pancreatic fistula, hemorrhage, pulmonary complications, and sepsis had higher significant odds ratio in the univariate analysis, and in the multivariate analysis, only the postoperative pulmonary complications and postoperative sepsis had significant odds ratio, leading to mortality. This slide shows the various histopathological outcomes of the resected specimen. The majority of the patients had adenocarcinomas, that is 127 patients. The right-sided pie diagram shows the different sites of adenocarcinomas of the patients. The majority were ampullary carcinoma of 67%, followed by pancreatic ductal adenocarcinoma, cholangiocarcinomas, and duodenal adenocarcinomas. We come to the survival analysis done using Kaplan-Meier plots. The entire cohort of the adenocarcinoma patients had a median survival of 30 months. When we do site-specific analysis, the ampullary carcinoma had the highest survival of 36 months, seen in the chart B. I would like to conclude my presentation by showing a comparison of the data of the outcomes of our center with the various high-volume centers of the world. In this chart, we see the rows marked with blue color are Indian studies. and the green ones are the international studies. If we see as a whole for our center, for the 10 years data, it seems the outcomes were much worse than the other Indian studies. But if we dissect this data into the various periods, from the first 5-year periods, the next 5-year periods, and then if we come to 2019 data, we see that the outcomes have significantly improved with time. And the mortality and the morbidity rates in 2019 are almost similar to the other Indian centers. But some of the centers, data from some of the centers like Winter et al. And Cameron et al. From the Johns Hopkins Hospital, who are the largest center for pancreatic duodenectomy in the world, and also from Tata Medical Hospital by Professor Shikhande et al., the data which was published last year, we see the perioperative mortality is very less. So we understand that our center has significantly improved with time, but we have a long way to go. Thank you.
Thank you very much for the presentation. And we invite any questions or clarification from the faculty or residents. Please wait for 30 seconds.
So whether alcohol use was also checked as a risk factor as part of the study?
Hello. Sorry, sir, I did not get the question.
Whether you had checked for alcohol use among patients, what proportion of patients had alcohol use as a risk factor for the carcinoma?
I had the data in my thesis, sir, but there was no significant association with alcohol, sir. So I did not include in my results, sir.
Okay, thank you very much for the presentation. And if there are no further questions, we'll move on to the second paper. Thank you very much.
Thank you, sir.
The second paper will be on evaluation of vitamin D supplementation in affecting the outcome of newly diagnosed patients with lymphoma, and will be presented by Dr. Arnab Bhattacharjee. Is it there?
Yeah.
She's sharing it. Dr. Arnab Bhattacharjee, are you there?
Yeah, Dr. Arnab, are you there?
Sir, my voice is audible?
Yeah, you are audible. Please proceed.
Yes, sir. So my screen is audible? My screen is visible, sir?
No.
So one second, sir.
I think you can stop sharing.
Sir, now it is visible?
Not yet.
Yeah.
Yes.
Please make it full screen.
Yes, sir. Sorry for
Yeah,
the
you are
interruption.
visible and audible. Please proceed.
Yes, sir. Sorry for the interruptions. Very good afternoon to my respected teachers and fellow colleagues. So today I'm going to present the study evaluation of vitamin D supplementation in affecting the outcome of newly diagnosed patients with lymphoma. Coming to the background, different studies have demonstrated inferior survival outcome for vitamin D deficiency in lymphoma patients. Supplementation studies of vitamin D in lymphoma are sparse in number. From India, there is hardly any published study evaluating the association of baseline vitamin D deficiency with lymphoma outcome. We intended to conduct this study to evaluate the association of vitamin D deficiency with lymphoma outcome. So coming to the some previous important studies on studying the role of vitamin D deficiency in lymphoma. So it has been seen that different lymphoma like NHL, DLBCL, T-cell lymphoma, Hodgkin's lymphoma, and follicular lymphoma, it has shown that vitamin D deficiency is associated with inferior event-free survival, overall survival, and lymphoma-specific survival. So coming to our methods, our study is a non-randomized interventional study on newly diagnosed lymphoma patients. Both Hodgkin's and non-Hodgkin's lymphoma are included. It was done in the Department of Medical Oncology with collaboration of Department of Endocrinology. Patient recruitment period was from August 2018 to January 2020. Coming to the study design, patients in this time frame were checked of serum vitamin D level, and we have taken vitamin D deficient cutoff as 12 nanogram per ml. So any patient with 12 nanogram per ml or more than that, we have taken vitamin D non-deficient, and we didn't supplement. And vitamin D deficient, if it is found less than 12, we have called it vitamin D deficient and we have supplemented. And we have checked overall response rate in both the groups. The primary objective was to study the association of baseline vitamin D level with overall response rate in patients with newly diagnosed lymphoma. Secondary objectives were to check the event-free survival between vitamin D deficient versus non-deficient group. And another secondary objective was to check the chemotherapy toxicities between vitamin D deficient versus non-deficient group. Coming to the inclusion criteria, all newly diagnosed patients with Hodgkin's and non-Hodgkin's lymphoma from the 7 to 8 years were included. Exclusion criteria were patients previously treated with any anti-malignant therapy, patients ECOG performance status more than 3, patient having renal stone or hypercalcemia, pregnant patient or lactating woman, and some NHL subtypes where the treatment management widely differs, like lymphoblastic lymphoma, primary CNS lymphoma, and Burkitt's lymphoma, we have excluded. So estimated sample size was total 160 with 80 in each group. Coming to the study procedure, patients' workup and treatment were done as per the departmental policy according to their respective lymphoma protocol. Vitamin D estimation was done at baseline, then at 3 months and 6 months for all the patients in both the groups. And vitamin D level were measured by chemiluminescence assay. Coming to the vitamin D supplementation protocol, all patients with baseline vitamin D deficiency were administered single intramuscular dose of 6 lakhs international unit vitamin D within 3 weeks of diagnosis. And if any patient at 3 months or 6 months in either group, if found to be deficient, vitamin D, again, same dose was supplemented. We have checked for hypercalciuria, that is calcium by creatine ratio more than 0.2 at baseline, day 3, day 7, 3rd week, 3rd month, and 6th month post vitamin D supplementation. And all the patients in both groups, we have given oral supplementation, that is 500 mg calcium and 250 international unit vitamin D as a daily requirement. Coming to the study outcome parameters, response assessment was done in Lugano criteria 2014. Overall response rate was assessed by combination of complete response rate but partial response rate. Event-free survival was taken from time interval from enrollment into the study to the date of relapse, refractory disease, or death, or date of last follow-up. Overall survival was taken from enrollment into the study to the date of death due to any cause or date of last follow-up. Chemotherapy toxicity was assessed using CTCAE version 5.0. Standard statistical test was used. Association of vitamin D, baseline vitamin D with response rate was carried out using chi-square test. The survival were analyzed using Kaplan-Meier survival analysis, and the last date of follow-up for the study was taken on 30th June 2020. This is the patient recruitment status. So from August 2020 to January 2020, we had 276 total lymphoma patients, out of which 125 patients were excluded based upon the exclusion criteria. And we have included 151 patients, out of which 56 patients were Hodgkin's lymphoma and 95 patients were non-Hodgkin's lymphoma. And regarding vitamin D status, we had 37 patients vitamin D deficient and 114 patients vitamin D non-deficient. These are the baseline clinical characteristics. So male patients were more common. ECOG status most of the patients were 0 to 1. Advanced stage disease were slightly more common. Around 1/3 of the patients had B symptoms, and around 1/4 of the patients had bulky disease. This is a baseline vitamin D status. So among all the patients together, we had 24.5% patients vitamin D deficient. In the Hodgkin's group, it has 32% patients vitamin D deficient, and NHL around 20% patients deficient. And median vitamin D level were 16.07 nanogram per ml in all patients, 14.9 in Hodgkin's lymphoma, and 16.9 in non-Hodgkin's lymphoma. We have checked the baseline vitamin D status with some baseline prognostic factors. So we have found female gender and hemoglobin level less than 10 were morely associated with, statistically associated with vitamin D deficiency. This table shows change of vitamin D status over time. So we have 151 patients, all the 3 vitamin D level available. And after 3 months, we had only 117 patients, the vitamin D level availability. And after 6 months, we had total 68 patients, vitamin D level availability was there. And we couldn't do for rest of the patients due to corona and due to other logistics. So at baseline, we had 37 patients vitamin D deficient. After 3 months with supplementation, 1 patient were persistently deficient, and 33 patients were corrected, and 3 patients we didn't have the data. And at 6 months, another 1 patient got vitamin D deficient, and 23 patients were vitamin D non-deficient, and rest of the patients were vitamin D. Rest of the patients' data were not available. Regarding baseline non-deficient patients, 12 patients had developed vitamin D deficiency after 3 months. And after 6 months, another 1 patient had developed vitamin D deficiency, all of which were corrected with 6 lakhs international unit vitamin D. Now, this table shows change of vitamin D level over time of the 68 patients whose all the 3 vitamin D levels were available. And we found that baseline vitamin D deficient patients, median vitamin D level were 9.8, which got corrected and increased to 29.5 nanogram per ml at 3 months. And it has maintained its level of 28.25 nanogram per ml at 6 months. And for vitamin D non-deficient patients, their level were more or less similar. So coming to our primary objective, that is comparison of the overall response rate in all the patients together. So we didn't find any difference in the vitamin D deficient versus non-deficient group regarding overall response rate. Then we have checked whether we could find any difference among the subtypes like Hodgkin's lymphoma, high-grade BNHL, low-grade BNHL, and TNHL. However, we couldn't get any difference between vitamin D deficiency and non-deficiency. This is a busy slide showing the toxicity profile of any grade toxicity or grade 3 or higher toxicity between all the between vitamin D deficient versus non-deficient group. However, no difference was found. Median duration of follow-up was 10.6 months, and median EFS and median OS didn't reach to all the patients or any of the subgroups. So 18 months EFS and OS we calculated. So for all patients, 18 months EFS was 64% and OS was 87%. And for vitamin D deficient versus non-deficient arm, again we couldn't find any difference of EFS versus EFS or OS. For Hodgkin's lymphoma, event-free survival, vitamin D deficient versus non-deficient, no difference. Hodgkin's lymphoma overall survival also separately, we couldn't find any difference. Similarly, high-grade BNHL, we checked separately and we couldn't find any difference of event-free survival or overall survival. Coming to the discussion, as previously mentioned, different studies have shown an association of baseline vitamin D, low vitamin D with the inferior survival of various lymphoma. And in one study, response rate was also found to be inferior with baseline vitamin D deficiency. However, in our study, no significant difference we could found in terms of overall response rate, chemotherapy toxicities, and EFS between baseline vitamin D deficiency versus non-deficiency group. So possible reasons might be normalization of the vitamin D level in almost 96% patients in our study, which probably had overcome the adverse prognostic effect of baseline deficiency. Then one experimental model on DLBCL, it has found that there is an increased chemosensitivity when the chemotherapy and vitamin D were given in vitamin D deficient patients. And another reason might be small sample size and heterogeneity of the population. So limitations of our study, it is a non-randomized study, small sample size, heterogeneous patient group, short follow-up period, And on around half of the patients, we couldn't have all the serial 3 values of vitamin D. Strength of the study: it is the first Indian study to evaluate the role of vitamin D deficiency in lymphoma. It contributes to the very sparse data on effect of vitamin D supplementation on lymphoma outcome, and single intramuscular dose of vitamin D is safe and efficacious in long-term correction of vitamin D deficiency. So in conclusion, no significant difference was observed in terms of overall response rate, toxicity, and event-free survival in vitamin D deficiency compared to the non-deficient patients, and a larger study with longer follow-up period and vitamin D supplementation in randomized approach might probably clarify the role of vitamin D deficiency in lymphoma. Thank you, sir. Any questions, sir?
Yeah, thank you very much for the presentation. And one clarification I'm asking is, you included kids from 7 years to 14 years as well, correct?
Yes, sir.
Will it have any effect, especially in the growing age, in the
Sir,
assessment of vitamin D?
So there were multiple studies, not in lymphoma, but in normal population as well as in vitamin D deficient non-cancer population. So there was all the study have shown that there is no difference in adult versus pediatric regarding the vitamin D supplementation. And like we can give 3 lakh international unit, or we can give 6 lakh international unit, and we can give orally also. And orally also different dose schedule are there, like 10,000 unit or 25,000 unit in different schedule, like weekly or 4 weekly. And but there was no such difference we can found between adult patient versus pediatric patient. So we have taken the same cutoff and we have taken the same supplementations.
Okay. Are there any other questions from faculty or residents? We'll wait for 30 seconds more. Yeah, please proceed. Hello. Are there any questions? If there are no further questions, thank you very much for the presentation, and it was a methodologically very good study.
Thank you, sir.
Thank you very much. Okay. We'll proceed with the next presentation.
Yeah. Our next session will be on case report. There are 3 case reports to be presented. The first one will be from the Department of Medical Gastroenterology and Radiodiagnosis and Surgery. It's about a rare complication during EUS guided gastrostomy successfully managed with biliary metal stent. So I call upon Dr. Pradeep V to please share his presentation.
Yes, madam. Hello?
Yeah, please make it full screen.
Yes.
You are audible. Please make it full screen and start presentation.
Okay, sir. Okay. Thank you. Okay. Good afternoon, everyone. First of all, on behalf of Medical Gastro Department, I would like to thank Jipmer Scientific Society for giving this opportunity. So here I am presenting one of the rare complications of the endoscopic cystogastrostomy, and that was successfully tackled with biliary metal stent. So case based on a 30-year-old male without any comorbidity, and he had a habit of taking alcohol around 80 to 100 grams per day with occasional binge drinking for 5 years. And he presented in Jipmer in December 2019 with complaint of abdominal pain and vomiting, and he was diagnosed to have alcohol-related acute pancreatitis, and that was managed conservatively. And after that, he was asymptomatic for 1.5 months. In February 2020, again he had a complaint of abdominal pain, and later on he also developed epigastric swelling, vomiting, and he lost 6 kg of weight over the period of the 1 month. Otherwise, there was no history of fever, jaundice, hematemesis, or melanoma. On examination, he was vitally stable, and per abdominal examination revealed 15 into 10 centimeter tender epigastric mass So further blood investigation was done, and blood investigation were unremarkable except hypoalbuminemia and mild anemia. US abdomen was done to characterize this epigastric swelling, and US abdomen shows 19 into 17 into 10 centimeters pseudocyst and epigastric region. These findings were confirmed in the CT. Here we can see in the cross-sectional as well as in coronal view, the homogeneous collection of the almost same size. We can see with the mature wall formation, and there was an avascular window to puncture the cyst. So we have posted this patient for US guided drainage. Patient was posted under general anesthesia. We have passed the US scope in the stomach, and using the Doppler, we choose the avascular plane to minimize the risk of the bleeding. We avoid the collaterals, and in avascular plane, we puncture the cyst using the 90 gauge needle. Here is the video showing the procedure. Here we can see this is the cyst and this is the needle. We puncture the using the 19 gauge needle, and after that we try to dilate the drag using the 6 branch cystotome with the pure cutting current. But while trying to dilate, here we can see the bleeding was noted inside the cyst, and we in Doppler we can confirm. You can see here we have confirmed the flow of the bleeding inside the cyst. So it was the active spot of the altered bleeding. So what did we do? We plan to keep one self-expanding metal stent to prevent this bleeding. Here actually ideal thing is there to keep the lamps, lemon-effacing metal stent, but we didn't have. So we plan to keep one self-expanding metal stent. This is the GI lumen here we can see, and this is the metal stent in right upper corner. We insert the metal stent over the guide wire inside the cyst. So metal stent was expanded. Yes, here we can see after expansion, yes, this is the expansion. We have passed the metal stent over the guide wire, and after the expansion of metal stent, bleeding was stopped immediately. So after that, we also passed one double pigtail plastic stent through this metal stent over the guide wire. Yes, this is the plastic stent to prevent the migration of this metal stent inside the cyst and for continuous drainage of the cyst. So bleeding was stopped immediately after the depletion of this biliary metal stent, and after that, patient was observed for 1 day. After that patient was observed for 1 day, he was started on IV fluids and antibiotics, and next day was vitally stable and asymptomatic. And per abdominal examination did not reveal further any epigastric mass. So patient was started on oral feed, liquid, and gradually escalated. And further scan was done. Here we can see compared to this previous scan. In the follow-up scan, there was a significant decrease in the size of the cyst with metal stent was there in C2. So patient was discharged in vitally stable condition, asymptomatic condition, and planned to remove the stent after 4 weeks. So coming to some management options for the pseudocyst, it can be a surgical drainage, USG guided percutaneous drainage, and recently one new option is the endoscopic drainage, particularly using US guided. Here US guided, we can see the collaterals, any pseudoaneurysm or any other abnormal vessel. We can avoid this vessel and we can choose the avascular plane to minimize the risk of the bleeding. And is also technical more success compared to this traditional. And this US guided technique, it is a less invasive and safe compared to this surgical drainage and particular drainage. So it is a standard of care nowadays for management of this pancreatic pseudocyst. But bleeding still may occur in 1 to 5% of cases. It can be either due to small missed venous collateral, or sometimes some pseudoaneurysm may collapse inside the wall of the cyst. So once we decompress the cyst, pseudoaneurysm may open and bleed. So if bleeding occurs, sometimes a mild to moderate bleed we may tackle with the balloon. We can keep the balloon at the entry side, inflate the balloon, and give a tamponade effect. Or hemospray may be useful. But sometime in the massive bleed, like in this our case, the patient may require the angioembolization of the vessel, or sometimes the surgical exploration and the ligation of this culprit vessel. Recently, some role of the self-expanding metal stent is there, as we have done in our case. Some cases have been reported to stop the bleeding during the cystogastrostomy using the self-expanding metal stent. We can keep self-expanding metal stent between the stomach and cyst like this. So entry-side blood vessel bleeding we can stop by virtue of its tamponade effect. When more advantage, it also provides the access to the cavity. So any further therapy like necrosectomy is required, we can do. But this metallic stent has its own complication, long-term complication will keep, like the perforation, bleeding. So we should remove the stent after the 3 weeks. So here take-home message is there. US guided transmural drainage is standard of care for pseudocyst, but they require high skill and expertise. It is relatively safe, but still complication may occur into 1 to 5% case, like occur in case. So availability of device in armamentarium is needed, and always we should plan for multidisciplinary approach to tackle such case. Thank you for your listening.
Yeah, thank you very much. I have a small clarification. The stent looks inside. Maybe we are seeing the only one cut of the CT. That might be the reason. Is it dislodged?
Yes, sir. Yes, sir. Actually, one cut of the only CT, sir, I could place. So that's why, sir, it was looking like that, sir.
Okay. Any questions from residents or faculty?
I have a question. I'm Krishna Prasad from surgery.
Yes, sir.
This one, was the stent removed during the follow-up?
Actually, sir, patient we called after 4 weeks, but he lost follow-up, and after that we further he could not come. Actually, patient lost follow-up, sir. So
one of the complication of metallic stent is stent migration leading to further complication.
Yes, sir. It can be there. Ideal thing is we should remove after 3-4 weeks. But follow-up, he received phone, sir, 2 weeks back. He's fine now. And for that's why actually he's not coming. He's telling he's fine asymptomatic. So he's not willing for any removal, sir.
Would you like to remove the stent if he comes for to you?
Yes,
for
sir.
the
Obviously, we call 3-4 times because complication may occur. And studies is showing, sir, 10% patient may have some, means once the cyst collapse, after that it may erode, sir, opposite wall. Sometimes bleeding and may pseudoaneurysm formation, migration. So blockage of stent itself may lead to infection. So obviously we like to remove.
Thank you. That's all from my side.
Okay, sir. Okay.
Yeah, hi, nice presentation. Just 2 questions. Does this patient had any splenic vein thrombosis?
No, sir. No, sir. CT-wise, no mesenteric vascular thrombosis was there, sir. To rule out that only we have CT.
And in case if the stent has migrated into the pseudocyst, so how will you remove it?
Sir, migration in the pseudocyst, sir, suppose an issue depends on axis of stent, sir. Instead, suppose it's maintained as axis, so we can enter the scope and using red tooth, we can try to remove, sir. So, and suppose it is not maintaining axis, then surgical exploration is the only option, sir.
Okay, thank you.
Yes, sir.
We'll wait for 30 seconds more for any other questions. Okay, if there are no further questions, thank you very much for the nice presentation and very good case report. Thank you very much.
Okay, thank you so much. Thank you, sir.
We'll go on with the next case presentation.
Yeah. Next presentation will be from the Department of Ophthalm and Emergency Medicine. It's on sinus bradycardia following single-day use of timolol eye drops in a healthy young adult, a rare case report by Dr. Sandeep Sarkar.
Am I audible, ma'am?
Yeah, you are audible, and please make it full screen and proceed.
Okay, sir. Good afternoon to respected all my faculty members. Today I'm going to present a case on sinus bradycardia following single-day use of timolol eye drops in healthy young adult, a rare case report. Timolol Valiate is a non-selective beta blocker. Besides prostaglandin, it can be considered as a first-line agent in all types of glaucoma. But it can reach the systemic circulation and can cause side effects like syncope, bronchoconstriction, bradycardia, conduction defects, and orthostatic hypotension. These side effects are most commonly seen in elderly population. Here we report a case where a young individual without any systemic comorbidity presented with bradycardia following just a single-day use of timolol. Here, a 35-year-old male presented with a history of blunt trauma left eye while playing with shuttlecock, with complaints of pain, redness, and blurring of vision in the left eye, with no associated headache and no pain on extraocular movements. His past history was non-significant. His general examination and systemic examination was within normal limit. On ocular examination, head position was erect, eyeballs were orthotropic, extraocular movements were free and full of all gazes. On visual acuity, right eye was having absolutely normal 6/6 vision and other structures was normal. But in left eye, he presented with a hand movement vision with conjunctival congestion and a edematous cornea. On anterior chamber, dispersed bloods were noted, and due to that blood, no further details were noted down. On Goldman applanation tonometry, intraocular pressure found to be raised than the normal. On dilated fundus examination, right eye was absolutely normal, but left eye there was no view, so we did a B scan. On B scan, there was no evidence of any vitreous hemorrhage or retinal detachment was found out. So summarizing our case, a 35-year-old male presented with pain, redness, diminution of vision in the left eye following blunt trauma, presented with left eye hand movement vision, high intraocular pressure with dispersed blood in the anterior chamber. So we made a provisional diagnosis of left eye closed lobe injury. We started him on timolol maleate eye drops, moxifloxacin, dexamethasone eye drops, humatropin eye drops, and oral NSAID drugs. And we advised him a semi-reclined position so that the blood gets deposited in the inferior quadrant. Due to the ongoing COVID-19 situation, we did not admit the patient and we sent the patient home with the advice to visit next day morning. Next day, patient returned to the OPD with complaints of giddiness and sweating since last night. So we shifted the patient to EMS where ECG was done, and the ECG was showing sinus bradycardia with a prolonged QRS interval. So it was managed in the emergency only with IV fluids, and a stat dose of 0.5 mg IV atropine was given. It was repeated after 2 hours. After 4 hours later, patient improved and heart rate both improved. But we kept the patient for 2 days. This ECG was taken 2 days later, which was showing normal heart rate with normal QRS complexes. We also did an echocardiography which ruled out no other patient is not suffering from any other cardiac diseases. So we concluded as there was no other reason for this patient to develop bradycardia, timolol-induced bradycardia was suspected. And we substituted the drug with a brimodulin-brinzolamide combination, and we continued the other drugs. On day 3, patient vision slightly improved, but his intraocular pressure raised to 56, which was managed with IV mannitol and tablet acetazolamide. But his heart rate was maintaining well. This is the slit lamp picture showing dispersed blood in the anterior chamber. 1 week post-trauma, patient vision nicely improved from hand movement to 6/9. Heart rate followed a sinus rhythm with 72. Intraocular pressure was maintaining on anti-glaucoma drugs. We did a gonioscopy on that day to see the angle structures. In this eye, we can see the angle structures are absolutely normal, but here we can see some damage which is signifying angle recession. We also did a full fundus evaluation, which was showing absolutely normal fundus in the left eye. So coming to the discussion, therapeutic range of timolol is around 10 to 40 nanogram per milliliter. So after topical instillation, 80% of the drug enters into the systemic circulation via nasal mucosa. Thus, it bypasses the first pass metabolism and it can mimic like a systemic administration. So 1 drop of 0.5% timolol can actually act like a 10 milligram of oral intake of the drug. It has already been documented that it is relatively contraindicated in patients with concomitant use of verapamil, digitalis, any other beta blockers. It's already been reported that this ionotropic action has been reported previously also, but mostly in elderly population and only after a considerable duration of time. This Pratt et al. Did a study with 287 patients who needed hospitalization due to the for bradycardia due to the timolol use. In their study, they find that there was no increased risk in those with less than 30-day usage, and variation of heart rate in their study was also very close to the minimal, less than 10 beats per minute. But in our case, it was almost 50. So severe sinus bradycardia in otherwise young individual following a single day use of topical timolol can be representation of a exaggerated drug reaction. But we did not do any re-challenge test due to the ethical issues. So conclude, timolol is a well-tolerated, cheap, easily available drug, but it has some systemic side effects. So the awareness regarding the systemic potential side effects among the prescribing doctors, especially the ophthalmologists, is very essential. Bradycardia is a potential adverse event following timolol initiation. Good history and close monitoring after history initiation can minimize the morbidity. And lastly, to counsel the patient regarding punctal occlusion, where after topical drop application of the patient, we should advise the patient to occlude the lacrimal sac area so that the absorption get reduced in the systemic circulation, and systemic side effect can also be reduced. Thank you.
Yeah, thank you very much. The occlusion of nasolacrimal duct is generally recommended for ophthalmic drops.
Sir, not for all drugs it is not for all drugs it is advisable, but mainly the drugs which are supposed to cause systemic side effects like timolol and atropine is also another drug. For this drug, we tell the patients to occlude the nasolacrimal duct so that the systemic absorption gets reduced and local action get increased.
We invite questions from residents and other faculty. Please wait for 30 seconds. Yeah. Yeah, if there are no further questions, thank you very much for the presentation. Thank you.
Thank you, sir.
We'll go ahead with the next speaker and next presentation.
Yeah. The next and the last presentation for today's session will be from the Department of Surgery and Cardiology. It's on pseudoaneurysm of the gastroduodenal artery, secondary to diverticulitis of the first part of the duodenum, a rare presentation of upper GI bleed by Dr. Sindhuja Ramanan. Dr. Sindhuja, are you there?
Can you hear me, ma'am? Can you hear me?
Yeah. Yes. Yes.
Yeah.
Please
Yes.
share
Oh, good.
the slide. Yeah.
Yes, ma'am. Yes, ma'am. Good afternoon, respected faculties. I'm going to present the case report on pseudoaneurysm of the gastroduodenal artery secondary to diverticulitis of the first part of the duodenum, which is a rare presentation of upper GI bleed. Acute upper gastrointestinal bleeding is one of the most frequent presentations to a surgical emergency, and in our part of geography, the most common cause of upper UJ bleed, acute UJ bleed is varicose bleed, and as soon as the patient comes, most of them respond to initial resuscitation. However, establishing a definite diagnosis helps in the prompt management of patient. But sometimes diagnostic challenges can be faced, but they should be appropriately addressed so that appropriate management can be done. So aneurysm of the gastroduodenal artery, it only 1.5% of splanchnic vessel aneurysms, this is the incidence. Splanchnic vessel aneurysms itself is very rare. And majority of this GDA aneurysm is secondary to pancreatitis, and they are pseudoaneurysms. And duodenal diverticula is nothing but outpouchings of the duodenal wall, and the most common site is second part of the duodenum in the juxtapapillary area. So this duodenal diverticulum is 90% of the time it is asymptomatic. But how it can complicate by causing diverticulitis, obstruction, bleeding, and very rarely perforation. So only one case of diverticulitis causing which was present in the second part of duodenum, causing pseudoaneurysm of the pancreaticoduodenal artery has been reported. And to the best of our knowledge, this is the first reported case of pseudoaneurysm of the GDA secondary to diverticulitis of the first part of the duodenum. So coming to the case report, the patient was a 70-year-old male with no comorbidities. He presented to the emergency with history of hematemesis. It was a single bout of 800 ml of fresh blood. That was his complaint. He had no other complaints, no history, similar history in the past. He was a chronic alcoholic and a smoker, and his last binge of alcohol was 2 months before the day of presentation. Otherwise, no significant family history as well. So on general examination, patient had severe pallor, and his abdominal examination revealed mild guarding in the upper abdomen, and per rectal examination revealed melena. Rest of his systemic examination was normal. On arrival, he was resuscitated initially with fluids and with 1 unit of packed cell. His BP, as soon as 1 unit of packed cell was given, his BP initially picked up to 100 systolic BP. However, it did not maintain, and it did not maintain to such an extent that despite multiple transfusions, he had to be started on inotropes. However, we had inserted a nasogastric tube, and 1 liter of only dark altered blood was there. There was no fresh or frank blood. It was a dark altered blood, but BP was going on deteriorating. So after initial around 1 liter of dark altered blood, there was no fresh blood. We had confirmed the position of the RT as well. We had even given wash once to confirm that there is no active bleeding, but still there was no further bleeding in the RT tube, but patient was worsening with increased requirement for inotropes. He was initially suspected to have variceal bleed since he's a chronic alcoholic. And there was a drop in hemoglobin, higher requirement for inotrop despite multiple transfusion. He was resuscitated with around 6 to 7 units of Paxil over the course. Since the patient was having a poor condition, the UG endoscopy could not be attempted because of the poor general condition. So since there was no fresh blood in the RT and patient had higher requirement of inotropes, small bowel pathology was suspected, and we got done CECT for him. And CECT, initially it was very difficult to pick up the finding, but because of strong suspicion and no other possibility, we had to see the CT very meticulously and in finer cuts and in multiple various sections. And after multiple and meticulous viewing of the CT, we found that there was outpouching of the first part of a duodenum, and there was a aneurysm, which was a very, very small aneurysm, 0.6 cross 0.5 centimeter adjacent to the diverticulum, with extravasation of blood into the diverticulum. And inflammatory changes were seen in the diverticular wall with the possibility of an impending rupture. So as soon as we saw this, we planned for DSA, which showed the presence of a pseudoaneurysm. As you can see here, the yellow mark is showing the pseudoaneurysm in the arterial phase, abutting the diverticulum, which is marked with the red mark. And as you can see, it is not very prominently visualized, and it had to be seen multiple times. However, we had to see it in various sections, and in coronal section of the CT, we could see that the GDA pseudoaneurysm is supplying the D1 diverticulitis. It's a very small aneurysm. And so we had to take the patient immediately to DSA. So we took him to DSA. DSA showed pseudoaneurysm of the GDA, but one thing to note here is that it was, at the time when DSA was done, it was not actively bleeding. However, we took a call and we decided to coil embolize the patient, and we had deployed a coil. So since there was a GD and we could not find any other source of bleeding, so we have coiled the aneurysm, and diverticulitis, since it was not a very complicated diverticulitis, we had addressed it only with IV ceftriaxone. So this is the picture where coil was deployed. And the outcome was that immediately after coiling was done, patient's hemodynamic status improved immediately, and he responded to further transfusion, and his BP picked up, and his hemoglobin was improving, and his general condition improved, and he was discharged within 1 week. And we had followed the patient 6 months after the procedure, and he's doing well with no complications. So just to discuss, GDA pseudoaneurysms are very rare. As such, flanking vessel aneurysm is very rare, and GDA is very rare. And only 7.5% of them are symptomatic. And the most common presentation of GDA pseudoaneurysm when they become symptomatic is GA hemorrhage secondary to aneurysmal rupture. So gold standard for diagnosis is visceral angiography. However, when we do a triple phase CECT, we can see the antecedent cause, which we can address appropriately. So the management is endovascular or open approach, but endovascular is preferred. Endovascular is the preferred approach because patient can be addressed immediately with no complications. When it is multiple attempts we have done in endovascular procedure, then we have to resort to open approach, and ligation and excision of the aneurysm we have to do. And if there are any further complications secondary to diverticulitis, we have to approach this as well. To conclude, I have a few take-home messages. So when the UJ bleed cause is not clear and in a very deteriorating patient, unlikely to have a variceal bleed, CECT should be done promptly, and it should be looked to see for any cause of aneurysm bleed. And especially when it is not very evident on CECT, the suspicion has to be more, and the CT has to be viewed more meticulously. And GDS pseudoaneurysm is a rare entity with the duodenal diverticulitis as etiology not reported so far. Rupture of the pseudoaneurysm leading to UJ bleed is its most frequent complication, and with coil embolization should be considered as the first line of treatment, and surgery should be reserved for failed cases. Coil embolization has very less morbidity, and establishing a timely correct diagnosis would reduce the patient's morbidity and mortality without exhausting much resources, because we had to transfuse this patient multiple times, and especially in times like COVID when the resources are not much. Thank you.
Thank you very much. Do we have a risk of necrosis here? Because of the embolization?
Possibility is there, sir, but other arteries are there as well. So risk is there, but not totally.
Okay, we'll wait for 30 seconds for any questions and clarifications.
There is a question from Dr. Palnival is unable to unmute.
Yes, Dr. Sindhuja, it was a good presentation. Are you able to hear me?
Yes, sir, I can hear you, sir. Thank you, sir.
Only thing is, did you during the follow-up, did you do endoscopy? Because I have few concerns. Like
Yes, sir.
duodenal diverticulum in the first part, primary diverticulum is very rare. Usually, in first part of the duodenum, in the bulb, secondary diverticulum are common. They are secondary to inflammation.
Yes,
so many times, like GDA aneurysm in the background of peptic ulcer disease or a duodenal ulcer in bulb is more common than a duodenum, true diverticulum in the first part of the duodenum and a diverticulitis. Diverticulum is rare and diverticulitis is even rare.
Yes,
so during the follow-up, did you do endoscopy in this patient? Because if there was a secondary diverticulum due to a peptic ulcer disease, you can still see them.
Yes, sir. Actually, we have not followed him up in person, sir. We have followed him up only through telecommunication. So we actually never got a chance to do endoscopy, sir.
Okay.
Yes, sir.
Okay, fine.
If there are no further questions, thank you very much, Dr. Sindhuja. Nice presentation.
Yes, sir.
And
Thank you, sir.
with this, we conclude today's JSS session. And on behalf of JSS, we sincerely thank the lead speaker, Dr. Muralidharan, and all the presenters of the scientific paper for their elaborative work as well as the presentation in the JIPMER Scientific Society. And we request all of you to send your presentation as a small abstract so that we can put it in our e-bulletin. Thank you very much once again, and we'll conclude this session. Thank you.